I come from University Hospitals of Leicester. Fortunately, we have the capability to do nearly 5 ECMOs at any point of time, and it is around 180 ECMOs per year. That is the volume the team deals with at this stage. Dr. Avash has set the stage for me, so my job is a little bit easier now to talk about ECMO. Basically, it's an adaptation of conventional cardiopulmonary bypass technology. It's not a treatment, it is not the cure. It just gives you time to allow the organ healing, whatever it is, either the lungs or heart or in multi-organ failure, sometimes in case of severe sepsis like that. This is how a baby on ECMO used to look like nearly 10 years ago at our institute. Can you see the baby somewhere there? I can show you. This is the one. And with all these gadgets around, we were using roller pump ECMO those days. This is the roller pump ECMO, infusion pumps there, CVVH for doing the providing renal support over here. That is extremely easy when you are an ECMO, and the baby was an oscillator as well. The picture has changed over the years. This is how it, the same picture with the baby. Now we use centrifugal ECMO, and this is the Centrimag mission we use for that from Levatronics. This, blood is sucked under negative pressure, so this is very, very useful methodology nowadays. So all the components can be so small as they are shown here, and this is from the Mackie, the console, water heater, pump here, and the oxygenator. So just to say that the components are becoming smaller and smaller. These are the 4 ECMO centers in UK. We are based here in Leicester. The other centers are at Great Ormond Street, London, Newcastle, and Glasgow. We are the only center which does ECMO in all age groups, neonates, pediatrics, and adults as well. It is teamwork. These are all components of our team. No single person claims excellence because of their own credit. This is the boss of ECMO service, Mr. Richard Formin. He had the vision and started ECMO service in UK 21 years ago. We have 19 nurses come ECMO specialists who does the work all the time, and the team consists of cardiac surgeons like Mr. Formin, intensivists, cardiac surgeons, ECMO specialists, physiotherapists, and all. I want to run through a few of the slides showing the ELSO figures, Extracorporeal Life Support Organization figures. So regarding pediatric ECMO, this is the world experience. There were about 4,770 cases in the respiratory, another 5,000 odd in cardiac fields, and extracorporeal resuscitation here for another 1,220, with survival figures nearly 56 to 39% as the varying figures. And this shows the annual runs of ECMO in the world as reported to ELSO registry form, around 250 pediatric ECMO runs. Respiratory. These are the respiratory causes for putting the children on ECMO: viral pneumonias, bacterial pneumonias, pneumocystis, etc. These are the cardiac runs, around 100 cases in a year at the moment, varying between 180 to 140. This is about the worldwide figures. So what happens to our own hospital, Grenfell Hospital, where we run? Pediatrics, they don't contribute a lot to the load of ECMO. They are a minor fraction. Over the years, we have done around 260 respiratory cases, 87 cardiac cases, and 4 ECPR cases, with varying success between 53 to 71% over there. This is for the respiratory and cardiac together. You can see the annual runs here. In 1989, when the program has started, during that year there was only 1 pediatric case which has improved over the years to nearly 12 cases, and here this is an approximation. ranging between 12 to 14 or so, with varying percentage of success between 83 to 65% over there. But of late, the figures have been improving. Pediatric respiratory runs by diagnosis, same figures as I told you, similar figures earlier. I want to rush through because of lack of time. Cardiac runs by diagnosis, congenital cardiac defects and cases of post-cardiac arrest, cardiomyopathy and myocarditis. These are the other cases which we put on ECMO for cardiac reasons in pediatric age group. So when a child is failing, we go, these are the various reasons for which they need ECMO in the pediatric age group. Respiratory failure from any cause like pneumonias, ARDS or aspirations, cardiac cause in case of prolonged cardiopulmonary bypass, if they cannot come off bypass post-operatively, or heart failure with respiratory failure and shock states, secondary to sepsis, etc., and multi-organ failure, they may need ECMO, they may get better with that as well. You try all the life-saving measures before going on to, we don't take it very easily. We explain to parents about what are the possible complications of ECMO and what we take, put them on ECMO only as a last resort. We don't do them as the initial resort really. There are two modes of ECMO, veno-venous and veno-arterial. Veno-venous mode, as the name implies, is the blood is drained from the right atrium, usually the major receptacle of blood, as it is the right atrium, through via internal jugular vein or sometimes through the femoral vein, and returned again by the same cannula into the right atrium again, via second cannula. Sometimes they may need a second cannula in the femoral or jugular vein. This depends on the size of the baby. Veno-arterial ECMO, blood is drained from the right atrium and returned into one of the systemic arteries. More often it is aortic arch via carotid or femoral artery. Venous ECMO, Richard Fomin, who was the founder of this ECMO program in Leicester, he had the vision to go for venous ECMO when the rest of the world was looking for veno-arterial ECMO. In the world, there is huge experience available on veno-arterial ECMO, but in our center, we prefer to do venous ECMO. This is because percutaneous cannulation is possible. You need not ligate any of the vessels, but it provides only minor cardiac support. In cases of hypoxia, once heart starts getting oxygenated blood, it does recover and your inotropic requirement will go down with that. Myocardial oxygen supply is excellent with venous ECMO compared to veno-arterial ECMO. The major problems with veno-arterial ECMO are monitoring is done via mixed venous saturations, because if you take an arterial gas, that just shows the pump oxygenated blood, it doesn't show about the utilization figures. So we monitor it via utilization. You have to ligate the carotid artery here. But the advantages are major cardiac support and immediate stability, and the ECMO will be provided on that. Indications: pneumonias of any cause, ARDS, secondary to trauma, burns, or aspiration, drowning, etc., and cardiac postoperative cases, as I told earlier. The referral criteria for pediatric age group population are high peak inspiratory pressure, high peak end expiratory pressure, and high FiO2, depending on the disease, speed of onset, and the stage. So you have to look at the progression of the disease as well over here. We take any duration more than 7 days, 7 to 10 days is a borderline, but more than 7 days is a contraindication for putting on ECMO. Intracranial hemorrhage is absolute contraindication. Irreversible disease and disease with poor outcome, limited heparinization, these are relative contraindications as well. This is how our circuit looks like nowadays. Cannula coming off from the venous end of the cannula coming over. This is the pump head here and console. They are just connected for the pressure measurements here, and it goes to the membrane oxygenator, and water heater is here for warming up or cooling it down to your required temperature, and the blood goes back to the baby. This is a picture of the water heater and activated clotting time ACT machine. We measure the heparinization with the ACT machine. Size of the cannula size, there is a size measurement by which you go at various age groups. Size matters because if it is a smaller cannula, due to increasing resistance over there, the flow may not be excellent over here, but with a bigger cannula, the flow will be good. At the same time, we also worry about the vascular endothelium adjacent to that. We don't want to cram the cannula into the vessel. There should be some space around the cannula as well. So that is very important job over there. Of late, we have switched over to Avalon Elite cannula, which is a reinforced cannula. It doesn't collapse. This is especially because of the centrifugal ECMO we have been using. Once you place the ECMO cannula within the right atrium, it looks like this. You suck the blood into the cannula, into the venous limb from the inferior vena cava, from the superior vena cava over here, and you reinfuse the blood into the right atrium, which goes through the root of tricuspid valve over there, and sometimes through PFO if that is patent. This is how the cannula position looks like. These are the various kinds of patients we get. The disease could be as severe as this, complete whiteout of the lungs. And this is a veno-arterial ECMO picture. The tip of the venous cannula is over here. This part is transparent, and this is the arterial cannula there. I don't want to go into specifics due to lack of time there. The various circuit components are cannula, tubing, which is usually of Tygon, bladder only in case of roller pump ECMO, not in centrifugal ECMO, pump, oxygenator, water heater, and pigtails. These are the various components of ECMO circuit. This is a roller pump ECMO here, and the bladder. Again, similar picture, how it starts rotating, thereby blood flows from one point to the other as it rotates. This is what we have been using these days. Centrifugal pump, Centrimag machine. With that, one pump will be used, and the other is just a standby in case of failure. And this is the water heater. This is the pump head. Fortunately, hemolysis with this one is nearly close to 1%, somewhere between 0 to 1%. We don't have any problems with hemolysis on this mission. This is for measuring the pressure, and this is how it looks like when the cannula is in situ. Rest ventilatory settings. We put the baby on child on minimal ventilatory settings when they go onto ECMO. This is universal criteria for any age group, pressures of 20/10, rate of 10, and FiO2 of 30%. If it is veno-arterial ECMO, we tend to increase oxygenation a little bit. Patient management consists of anticoagulation, diuresing to dry body weight, transfusion of the blood products, giving antibiotics to treat infection. Drugs and dosages will change as well, but due to lack of time, I may not be able to go into details. We take extreme measures to maintain the activated clotting time within 140 to 160 seconds. That is our unit policy, and we have been very successful with that. And we keep the platelet count above 45,000. There are various things to do. This is our everyday, day-to-day practice. So, it's difficult to cover within 15 minutes, but there are so many things in the routine patient management as well. Left-sided overdistension in veno-arterial ECMO can cause problems, so they might need vasodilatation and left-sided venting as well by the form of a cannula insertion over there or transatrial septectomy. When 70 to 80% of the gas exchange occurs through the native lung, then we start weaning the flows. Trial of ECMO is easy on venous. We just take the sweep gas off, or which is oxygen. But in veno-arterial ECMO, it's a bit difficult. You have to run the patient as well as the circuit as two different components. This is how a decannulation looks like in case of double cannulation over there at the femoral cannula over here, and after decannulation. ECMO is not a treatment but a supportive mechanism. Staff are very, very important for maintaining this process. They are really dedicated staff, and it is a lifetime practice as well. So we need close liaison between different referral centers as well, as we are a national referral center for entire United Kingdom. We go to various places by helicopter, for helicopter transfers as well. Needs a good patient care, good patient after care once these patients are transferred back to the referral centers. There is just one more slide. Can you bypass this, please? I want to show you about the mobile ECMO. Because of the facility we have developed over the past few years, this is the mobile ECMO picture. We put the whole circuit. This is the oxygenator and pump head over here, and the ventilator as well, and we take the patients from place to place or bring them to our own unit on the mobile unit. This has been very, very helpful. And the important message is it's used for prolonging life but not for prolonging death. So when we are not successful with the technique, or in cases of severe intracranial hemorrhage, then we need to discuss with the family that it is of no use and we had to stop the process. So it is extremely important to realize where we stop as well. Thank you very much.